Good morning. I'm Dennis Blair with the State EMS Office. When preparing for and responding to patients with suspected Ebola, close coordination and frequent communications are important among 911, PSAPs, and EMS personnel. Today we will discuss the protocol to screen for suspected Ebola virus disease cases, including Ebola first responder training guidelines. If you have any questions about anything being discussed, please call or email during this broadcast. The phone number and emails are on the screen now and will appear again later in this program. Also, the handouts are available online, but you need to register for this program in order to have access to these materials. Ebola is still out there. People from hot zones are returning every day to the United States. Alabama has many missionaries out there and they're coming home. Just because we are not hearing about Ebola does not mean the risk is still not there. For the past several months, we have responded with numerous resources, including hazmat. This has caused panic in many cases and shut down businesses and caused hardship for some people. We've now coordinated with the EMA, emergency managers, to develop a response guideline so we can lower stress levels while keeping responders safe. We have also requested PPE to be placed on every ambulance in the state, and hopefully we'll get those very soon. Today's faculty is Dr. Sarah Nafziger, who will be giving our presentation today. And Sarah, at this time I'll turn the program over to you.
All right, thank you very much. I appreciate everyone taking your time to be here today and to listen to this broadcast and participate in it. Hopefully what we learned today will be helpful as we respond to this disease outbreak. So our objectives today are to identify the signs and symptoms of Ebola and talk a little bit of basics about the disease, to describe the patient treatment cares for Ebola in the EMS setting in the state of Alabama, and to talk about the proper infection control, waste management, and environmental infection control procedures for EMS in the setting in Alabama. Well, first of all, we're going to spend some time, like I said, talking about some background information about Ebola. Ebola is a virus, and it's one of the viral hemorrhagic fever viruses. It's called a filovirus. It's a severe disease and has a high case fatality rate. There's no specific treatment for it, and there's no vaccine for it at this time, although some are in development. We don't know when they will be available. There have been a lot of Ebola virus outbreaks in the past. They've all been on the continent of Africa. It's happened many times, though. It was discovered in the 1970s, so there have been a lot of outbreaks of Ebola in the past. Ebola is a virus that lives in animals, so it's called zoonotic. Bats are the most likely reservoir, although we think it may live in other species of animals, such as fruit bats, monkeys, or the duiker, which is a small antelope, for all you hunters out there who are curious about that. The disease can spill over from infected animals into humans, either from contact with the animals or when you eat infected meat. So that's how the disease gets from animals to humans. And this is a little diagram just demonstrating that process epidemiologically. Now, what makes this Ebola outbreak from the ones that we described in the past is that this is the largest one in history. There have been more people who have been infected with it and more people who have died from it. The CDC's response to Ebola is the largest international outbreak response in CDC's history. So that's why you're hearing a lot about it in the news. It is a big deal, and that's why it's had so much attention. Here's a map that shows a little bit about the cases of Ebola. They've been predominantly in the countries of Guinea, Sierra Leone, and Liberia, although we also have some cases in Mali right now. Just to give you some idea of the magnitude of this problem, if you look at the data as of December 7th, which was just a few days ago, there have been almost 18,000 cases of Ebola. Only a little over 11,000 of those have been laboratory confirmed, but we're pretty sure around 18,000 cases. And over 6,000 people have died from this outbreak in particular. So you can see it's a big problem. Here's a breakdown of kind of where the cases have been, where the deaths have been. And as you can see, just like we discussed, Guinea, Liberia, Sierra Leone, those are the three countries that are the hardest hit. But we've also had some cases in other countries, including the United States. So let's talk a little bit about some definitions as we talk about this disease outbreak. This is a little bit of public health lingo, if you will. When we talk about Ebola cases, we talk about person under investigation, or PUI, and you'll see that commonly in our literature. And what that means is a person who has a fever, Ebola-compatible symptoms, and has epidemiologic risk factors within the 21 days before the onset of their symptoms. So that means they've been somewhere where they could have been exposed to Ebola. Now, as opposed to a person under investigation, the other thing that you'll hear us talking about is a confirmed case. And that's when you have a patient who has laboratory-confirmed diagnostic evidence of an Ebola virus infection. So what are the symptoms of Ebola? Well, anybody who's a healthcare provider has probably seen a patient with a lot of these symptoms in the last shift that you worked. Severe headache, fatigue, muscle pain, vomiting, diarrhea, abdominal pain, unexplained hemorrhage. All of these can be seen with Ebola. So as you can see, just based on the clinical presentation, it's very hard to figure out whether or not someone has Ebola, influenza, or some other viral syndrome. So let's talk about the Ebola cases in the United States. Ebola has been diagnosed in 4 people in the United States. One, who was the index patient, traveled to Dallas, Texas from Liberia, and 2 healthcare workers who cared for him and were subsequently infected. And then there was also 1 medical aid worker who was in Guinea working and traveled back to New York City who had Ebola virus disease. So that's 4 total patients. One of these, the index patient in Dallas, actually died from the disease. Now, also during this Ebola outbreak, 5 healthcare workers and 1 journalist who were infected with Ebola virus while in West Africa were transported to hospitals in the United States to receive treatment. 5 of these patients have recovered. One of those healthcare workers died on November 17th after being transported from Sierra Leone to Nebraska Medical Center. I think it's important to note that his disease was in a very advanced stage by the time he was medevaced to the United States, and he unfortunately died from his illness. So let's talk about how Ebola virus is transmitted. So the virus is present in really high numbers in blood, body fluids, and excreta of symptomatic Ebola-infected patients. So there are a lot of opportunities for human-to-human transmission. Let's talk about some of those ways. So the first way is direct contact, such as through broken skin or unprotected mucous membranes, that's like your eyes or your mouth, with an Ebola-infected patient's blood or body fluids. So that's the first way. Another way is a Sharps injury, so say a needle stick. If you have an Ebola patient who has that you use a needle on and then you accidentally stick yourself with it, that's another way that you could catch Ebola. Direct contact with the corpse of a person who died of Ebola virus disease, that is another way that a lot of people become infected with Ebola. And then also through indirect contact with an Ebola-infected patient's blood or body fluids via contaminated objects. So say someone had Ebola-infected feces or vomitus on their hands and touched a doorknob, and then you touch that doorknob, that's another way that you could catch Ebola virus. So Ebola, finally, another way is that Ebola can be transmitted with contact with the blood, fluids, or meat of an infected animal. So a couple of important points about transmission of Ebola, and this is something that is very important that you need to remember. People who are infected are not contagious until they become symptomatic. So somebody who is not sick, who is not feeling ill, who doesn't have symptoms, they are not contagious to other people, and that's very important to remember. The infectiousness of those body fluids increases as the patient becomes more ill. So the sicker they get, the more contagious they are. So that's why remains from people who die from Ebola are so very highly contagious or infectious, because they have very high viral loads at the time of death. Here's another really important point that I want you to remember. That's human-to-human transmission of Ebola virus via aerosols or inhalation has not been demonstrated. That's very important to remember. So the CDC has a lot of resources that are on their website, and I know this is a small slide and difficult to read, but I put these up here because I want you to recognize these pictures and go to CDC's website and look up these resources, because there are a lot of posters. There are a lot of things that you can print out and hang on the wall, things that you can share with other healthcare providers or with your patients that talk about how Ebola is spread and just cover some of these basic points. All right, let's talk about how the disease presents. We said already, you know, some of these symptoms of Ebola look a lot like other things. So let's talk a little bit about how it looks. Well, when you first become ill in the acute phase, it typically is 8 to 10 days after the initial exposure, but it can be anywhere from 2 to 21 days. And that 21 days is where we get that 21 days in our screening. When you screen someone with recent travel, then 21 days. That's where this comes from. So if you are exposed to someone with Ebola, you can get Ebola up to 21 days later. That's where that came from. The signs and symptoms initially when you first start to get sick are usually fever, chills, myalgias, that's muscle aches, malaise, anorexia. So they just don't feel well. And as you know, that looks like a lot of other things can present that way. After about 5 days, that's when these patients start getting GI symptoms, things like nausea, vomiting, copious watery diarrhea, and abdominal pain. Sometimes they also have headaches, conjunctivitis, hiccups, rash, chest pain, shortness of breath, confusion, and seizures. Now, when we think about Ebola virus, a lot of times we think about the hemorrhagic component because it's a viral hemorrhagic fever. But really, you only see the hemorrhagic symptoms in about 18% of cases, so that's really not very many cases where you see the hemorrhagic symptoms. Now, something that's important to remember, particularly if you've traveled to West Africa, is there are a lot of other things that can present very similarly to Ebola. Things like malaria, typhoid fever, meningococcemia, Lassa fever, pneumonia, a lot of other infections that you can catch when you travel anywhere in the world, but particularly in West Africa. So it's important to remember that just because someone has flu-like symptoms traveling from Africa, that doesn't mean they necessarily have Ebola. There are other things that they could have caught as well. So once you have these early symptoms, they progress with Ebola. Unlike other diseases, what we see, if it's untreated, what we see is they progress to hypovolemic shock, multi-system organ failure. A lot of times they'll have the hemorrhagic disease, but not always, and ultimately death if the disease progresses. Now, patients who survive, they typically show improvement 6 to 11 days after symptom onset. And the patients who have more severe early symptoms, those are the ones who have higher fatality rates. So the more severe the disease is early on, the greater your chance of dying from the disease. In parts of rural Africa, they've seen fatality rates of around 70%. And that makes sense if you think about it, because that's where patients have the least access to care and are going to have delayed access to care. What we're seeing is that if you have patients with Ebola, if you provide them with intensive care early, especially things like IV fluids, repletion of their electrolytes, things like their sodium, magnesium, potassium levels, if you can replace those, that seems to increase the survival rate. So patients who get early aggressive care tend to do better. These patients have the physiology that you see with hypovolemia and sepsis. So we give them aggressive IV fluid resuscitation and hemodynamic support. And like I said, they have electrolyte and acid-base abnormalities. The patients, you try to manage their fever symptomatically and their gastrointestinal symptoms with, medicine to keep them from vomiting, to control the diarrhea. But we have to avoid the use of NSAIDs, things like ibuprofen, because that can exacerbate some of the other problems with the disease. So we don't want to give them aspirin, we don't want to give them ibuprofen. Tylenol would be a good choice, or acetaminophen for management of fever. The multi-system organ failure can develop, and that may require more aggressive interventions such as mechanical ventilation or oxygenation, even dialysis. And sometimes we have to do things to correct their coagulopathy, their bleeding disorders, with blood transfusions, not only of packed red blood cells, but of platelets and fresh frozen plasma. Let's talk about patient recovery. So we're seeing a case fatality rate overall of about 35%. So in the West Africa outbreak that we're seeing right now, about 1 out of 3 patients who are infected with Ebola die. The case fatality rate is likely much lower for patients who have access to intensive care. So when they don't have access to that care, the fatality rate is much higher. Patients who do survive often have signs of clinical improvement by the 2nd week of illness, but once they survive the initial period of illness, they have a prolonged convalescence. So it takes them weeks to months to get back to normal after they recover from this disease. So let's talk about some time periods. This is a public health talk, so anytime we talk about public health issues, we have to talk about time periods, right? So in this Ebola outbreak, what we're seeing specifically is the average incubation period is 11.4 days. So from the time of exposure to Ebola to the time you get sick is about 11.4 days for most people. The average time after symptom onset to patients being admitted to the hospital is 5 days. The average time from symptom onset to discharge from the hospital is 16.4 days. And for patients who die, the average time after symptom onset to death is 7.5 days. The average time in the hospital for these patients has been 6.4 days. And let me remind you that this data is from West Africa predominantly, not from the cases that we've seen in the United States. That's where this data comes from, is this large cluster of patients in West Africa. So let's talk about what CDC is asking us as healthcare providers to do in the United States, and what ADPH is asking you as EMS providers to do, because you're a critical part of the healthcare system. So the first thing is to assess patients for Ebola-like symptoms. So that is going to collect a lot of patients. As we all know, you see patients who have those symptoms every single day. It's flu-like illness. So when you see patients who have those kind of symptoms, the next step is to ask them about their travel history to determine if they've traveled to West Africa within the last 3 weeks, or if they've had potential exposure to Ebola patients in other scenarios. And then finally, we want you to know what to do if you have a patient who has Ebola symptoms. So what do you do? First thing is you want to properly isolate the patient and keep them away from everyone else. Well, the CDC says that we should put the patients in a separate room with a private bathroom or a covered bedside commode. Well, in the EMS setting, we may not have that luxury, and we're going to talk about some of those EMS-specific details in a moment. Then the next thing you do is follow infection control precautions to prevent the spread of Ebola. You want to avoid contact with the blood and body fluids of infected people. It's just as simple as that. And then the third tier is you're going to contact your state or local health department if you have a suspected possible case of Ebola. And like I said, we're going to talk about the EMS-specific details of how we want you to do that in Alabama in just a moment. So we talked about, that's what the CDC is asking us as healthcare providers to do. So let's talk about what is the CDC doing. The CDC is actively screening people who are returning travelers to the United States. So people who have been abroad are being screened extensively at ports of entry into the United States. So predominantly what we're talking about is airports. CDC has listed several different tools out there on their website, and I would encourage you to go download those and take a look at them, that are basically screening tools to help find people who are high risk for Ebola so that we can keep an eye on those folks. And as you look at these, it's essentially the things we've just talked about. It's patients who have Ebola-like symptoms, who have possible exposures. Those are the people that we're looking for. And CDC, not only have they created these tools for catching people at ports of entry into the United States, but they also have developed these tools for evaluating patients in the emergency departments, in ambulatory care settings, such as urgent cares or private doctor's offices. So they've got a lot of tools out there that are available for us to use, and a lot of decision-making aids and nice pictures that you can download and print these things off and look at them, that are great tools for us as healthcare providers. So basically, here's another example of a great tool that's out there. The thing that is frustrating perhaps for us as EMS providers is most of these tools are geared for the inpatient setting and they're not EMS specific. So we're going to talk about that shortly. So CDC has created this interim guidance to provide the public health authorities with a framework for evaluating people's level of exposure to Ebola and initiating appropriate public health actions on the basis of their exposure level and clinical assessment. So what does that mean? Is basically all the screening that's going on. We have an algorithm from CDC to help us figure out who falls into which category. Are they high risk, some risk, low risk, or no risk? And that's based on a lot of details, such as exactly where they were, exactly what they were doing, exactly how close you were to someone who has Ebola, and that sort of thing. So basically, we're taking all these people who are at risk, we're evaluating them and placing them into a risk category, and monitoring these people is the bottom line. So we take these people, if we determine that you're high risk, then CDC and ADPH are working together to provide monitoring for these patients. Why is that important to us in EMS? That's important because if we get a call on a patient and they are in one of these categories, that would be a great thing for us to know on the front end, right? And I doubt that any of you have run a call and had this information ahead of time, but this is something that a problem that we're trying to solve with this algorithm we're going to discuss today. So CDC is monitoring these folks. ADPH is working with CDC to monitor these folks. We know who they are, we know where they are, and we're checking on them on a daily basis. So let's kind of shift gears now and really talk about the things that we're more interested in. We're interested in the EMS piece of Ebola screening. All right, so we start with screening, and screening starts with the public safety answering point. That's where we want those questions to be asked initially. Ideally, that will happen in every case, but not always. As we know, sometimes things fall through the cracks. Information is not always there. And so sometimes the screening may fall to the EMS provider on the scene. You may have a still alarm where the public safety answering point was not involved. So at every point in the game, you have to consider the screening piece. So if you have a patient with Ebola-like symptoms and the patient has traveled to a country with widespread Ebola transmission or been in contact with an individual with Ebola, then those are the patients that you really want to sound the alarms on and get some help. So when you see those two things, Ebola-like symptoms and risk factors to exposure, you want to implement your Ebola plan, and you want to call the Alabama Trauma Communication Center. Those are your actions if you have a patient with suspected Ebola. There's a screening tool that's available on the ADPH website, and you can download it. It's in the EMS toolkit, and I'll show you at the end exactly how to get to this. But this basically summarizes what we just talked about, all these screening things that you want to do. And this might be something that you might want to print out and put in the back of the ambulance, or print out and post around the station. These are things that you want to keep in mind. So let's talk about what happens when I call the Alabama Trauma Communication Center, or ATCC. This is not a trauma patient. This is not a stroke system patient. So what happens when I call ATCC? Well, what happens is the ATCC will connect you to an ADPH Office of EMS Medical Director. Most likely that would be myself or Dr. Crawford. And then we will be able to assist you in the risk stratification of the patient and provide guidance for your response based on that risk stratification and current CDC guidance. So when you call us and talk about that patient, we're going to talk you through it. We're going to be right there with you to help you figure out what to do. That may also involve us talking on the phone with the patient. So ATCC can get a three-way call going so we can get some history from the patient so that we can all work together to make the best decision to figure out how we can care for them safely. So as we've learned from our recent experiences, in many cases, we'll be able to determine by just talking on the phone that the patient may be at no identifiable risk for Ebola, and therefore we don't even have to implement Ebola precautions. And, that would be fabulous if we can determine that ahead of time so that we don't have to waste time, we don't have to waste personal protective equipment. We can just go ahead and take care of the patient rather than having to worry about Ebola. I want to make clear and make this so that there's no ambiguity. Calling the ATCC so that you can speak to an ADPH physician for consultation is mandatory in these cases where Ebola virus is suspected. So if you have a patient who raises those alarms, who has Ebola risk factors and the exposure history, is mandatory for you to call ATCC so that we can consult with you to help you figure out this patient's risk stratification and what the next steps are. Now, I know a lot of you have active medical directors who are very involved with your department, and this doesn't mean that you can't contact them as well. That's absolutely fine. This is not meant to usurp your medical director's authority, but this is meant to get ADPH involved early on so that we can help you with this risk stratification. The information coming out about Ebola is changing on an almost daily basis, and we have access to that information, and we have access to the database of persons who are under investigation for Ebola. So we have a lot of information that we can help you with so that we can help you better care for these patients. All right, so let's say we've got a patient who we've decided does raise the alarms for Ebola, and the patient really, we need to treat them as an Ebola patient. Let's talk about the ways that we isolate that patient. Well, we are not in the hospital typically in the EMS setting. We're in an uncontrolled environment. So we're going to try to separate that patient from other individuals as much as we possibly can. For most of us, that may be in the back of the ambulance with the door closed, or if you're in a fixed structure, it may be in a room with the door closed. The bottom line is you want to limit exposure of people to this patient as much as possible. You don't want to expose any more people than you have to. Along those same lines, you're going to use the minimum number of EMS providers necessary to safely transport this patient. So a lot of times that's going to be a driver who has no contact with the patient and 1 to 2 EMS providers in the back of the truck. Now, when you move the patient to and from the ambulance, what you want to do is make sure you clear and secure the pathways of travel in order to avoid accidental contamination of bystanders. This is a lesson that some agencies have learned from some drills and some feedback that they've had. They did a great job in taking care of the patient and isolating them, but when they went to move the patient, there were bystanders who walked up and saw, the lights and sirens and all the commotion and wanted to know what was going on. So that is a very good pearl that we picked up from some folks who've had some drills. All right, let's talk about PPE, or personal protective equipment. You obviously do not want to have physical contact with the patient without donning the proper personal protective equipment. The routine for PPE for these patients is both standard, contact, and droplet precautions. We don't need aerosol precautions in these patients. There's 3 general principles that guide our PPE usage in the United States, and these are from the CDC, and they apply to us in EMS as well as in the inpatient setting. So principle number 1, rigorous training. The first time you put on your Ebola PPE should not be when you're caring for the patient. It should be ahead of time. You have to be trained in both how to put this PPE on and how to take it off. When you train, you find problems and you can fix those ahead of time. It's just, I can't emphasize to you how important it is to work that out ahead of time. The first time you put on this PPE should not be when you're caring for an Ebola patient. Principle number 2 is that you should have no skin exposed when your PPE is worn. So we don't want any skin showing whatsoever. So as you think about your PPE selection, I know a lot of people have different supplies available to them. Everybody's PPE is not the same. Unfortunately, we can't just go out and buy all new PPE right now. It's in limited quantities. It's difficult to get orders in. You may have to just work with the PPE you have. The principle that you want to adhere to, though, is that no skin is exposed when your PPE is worn. So make sure whatever strategy you have with your equipment, that your skin is not hanging out. Principle number 3 is that you need an on-site manager for PPE. So this is a person who knows how to don PPE. This is a person who knows how to doff PPE. This is a person who can watch you don and doff and make sure you're doing it right, who can talk you through it, and if there's a potential contamination, can point that out and help you through it. Now, most sites you're going to utilize the incident command system, but it may be that your incident commander does not need to be your donning and doffing expert, and you probably need to have a separate person if at all possible, because incident command is going to be busy with other things. So if you have the luxury of having an additional person, that would be a great idea. So a trained observer must supervise each step of every PPE donning and doffing procedure. Why is that important? Because you may say, gosh, I know how to do this. I've practiced it a lot. I'm great at it. I'm hazmat trained. It's very important because you never know. This is so important to make sure your PPE is on right, that you don't self-contaminate during the process. And I can tell you from personal experience, I've participated in several drills with this, and you'd be surprised at the little things that can happen where you accidentally self-contaminate, where you need that trained observer there to help you get through the process. So it's vital that you have that extra person there who can just talk you through it and supervise every step of the procedure. Well, let's talk a little bit about exactly what that PPE should be. So the CDC updated their guidance for that, and this is kind of the nuts and bolts of it. You need 2 pairs of nitrile gloves with extended cuffs on the outer pair. Now, a lot of people say, can I wear more than 2 pairs? If you want to, that's fine. This is the minimum. okay? You don't have to wear 3 pairs, but 2 pairs is what we recommend as a minimum. In some cases, 3 pairs might be a problem because it inhibits your ability to move your hands. You may not be able to function well in 3 pairs of gloves, but 2 pairs is really what we recommend. You need an impermeable gown that extends all the way down to mid-calf with boot covers that come up to the mid-calf. Or if you don't want to do gowns or you don't have gowns, you can wear a unibody suit with separate shoe or boot covers in addition to the suit. The reason for the separate shoe or boot covers is that if you're wearing a unibody suit, like a lot of people talk about Tyvek suits, for example, if the suit is ever going to fail, one of the places that could potentially happen is on the soles of your feet, on the bottom of your shoes, where you have a lot of friction. So that's why we recommend the separate shoe or boot covers. It's just to prevent any contamination from suit failure. Then you'll need an N95 face mask at a minimum, and a full face shield. Now, we used to talk about goggles with the N95 mask, and that has changed to a full face shield. And the reason for that is with goggles and an N95 mask, you're still going to have exposed skin. But if you have that full face shield, your whole face is going to be shielded. That way, if there's a splash, or if you get hot and accidentally reach up to scratch your face and forget, have an itchy nose or something, it'll protect your face and your skin. The next thing is you're going to have a hood, something covering your head that extends all the way down to your shoulders. And same reason, you just don't want anything hanging out. You want everything covered up. And then finally, the other recommendation is if the patient is having copious fluid production, we found it useful that if you can wear an impermeable apron. That's not necessary, but it's nice, particularly when the patient has copious fluid production, because that way you can take the apron off, and that removes a lot of the contamination that you've received. So when you talk about removing the PPE, this is where the high-risk process is in place. Obviously, putting on clean PPE, you're not going to contaminate yourself in that process, but taking off dirty PPE, that's where you can get contaminated, and it's a high-risk process. You should go through this process slowly and very methodically. You don't ever want to rush getting out of your PPE. It's a structured procedure, and you should do it with a trained observer in a designated area for removal to ensure that you're safe throughout the procedure. Once again, you do not want to get in a hurry. It's recommended that you have a procedure that's spelled out step by step by step, and have someone talk you through it so that you can take your time and do it the correct way. If you use tape to secure your PPE, like a lot of people prefer to do that, some don't. The downside of using tape is that when you remove it, you can see some splashing of fluids when you remove the tape because it's on there pretty securely. So if you're going to use tape, you need to practice and make sure you know how to remove it to avoid splashing fluids on yourself. So one consideration that a lot of people have adopted is when you're removing your PPE, is a lot of people like to disinfect the layers as they go. So especially if you have gross contamination on your PPE, is you can disinfect that before you remove it with disinfecting wipes prior to removing the PPE. And so that way you just kind of reduce your risk of self-contamination as you remove that PPE. You want to avoid splashing or spraying cleaning fluids onto your PPE, however, because when you do that, splashing and spraying, remember that you can accidentally contaminate yourself from a splash. So you want to be very careful and avoid splashing or spraying. So a lot of people prefer just using disinfecting wipes that have disinfectant cleaner on them. Another point about PPE that is not really in the slides but I wanted to make is that when you think about when you're removing your PPE and you get all the way down to the bottom layer of clothes, the question a lot of people ask is, well, should I throw these clothes away? What should I do? If they're grossly contaminated, obviously you want to throw them away. It's not worth the risk. A lot of facilities and a lot of agencies are choosing to use disposable garments underneath. So that's something that you might want to consider. But definitely, I think the safest thing is to throw those away, but it's not required unless they're grossly contaminated. All right, so let's talk about training. Where can I find some good training? If you look at this website, and I'd like everybody to take a minute, if you're watching, to write this website down. or you can search it on YouTube as well. But CDC has created some fantastic PPE training reference materials. They're videos, and you can actually go through and pick exactly what PPE you have, because everybody has a different ensemble of supplies that they've selected. So you can pick exactly what you have, and they have fantastic training videos that have been created specifically for this, and that talk you through the whole process. And they have some other resource materials there as well. So I would strongly, strongly encourage you to take a look at those. It's well worth your time. All right, now let's talk about actual patient care. So before we move these patients, it's completely acceptable to remove the medical equipment out of the patient care compartment of your ambulance to avoid contamination of that equipment. I know EMS equipment is very expensive, and none of us have the luxury of having a lot of money to buy extra equipment. So it's perfectly acceptable to remove that equipment before you transport these patients to avoid contaminating the equipment. Really, when you care for these patients, you only want to use medical equipment that's dedicated for the care of Ebola patients, and preferably you would like to use disposable equipment. So, for example, disposable blood pressure cuffs, that sort of thing. Anytime you can use disposable, that's better. You want to keep your medical equipment use to a minimum. These patients are authorized for basic life support care only in the EMS setting. Now, once they get to the hospital, they'll get care that goes beyond that. But in the EMS setting, they're authorized for basic life support care only, because the EMS is an uncontrolled environment. There's no treatment for this disease. There's no vaccine for this disease. And the last thing we want is for our EMS providers to get infected as well. So we want you to provide basic life support care for these patients and get them to the hospital so that they can have more advanced care. So what does that mean specifically? Needles and other sharps should not be used in the EMS setting for these patients. We're going to avoid any aerosol generating procedures such as airway management, suctioning, inhaled nebulizer treatments, and cardiopulmonary resuscitation. Finally, you want to use caution with these patients, as sometimes, particularly late in illness, they may suffer from delirium, they may be confused. They may have erratic behavior, so you want to be very cautious with these patients as you approach them. All right, let's talk about medical waste for a few moments. So, as you know, caring for a patient while you're wearing PPE, you can generate a lot of waste. So, medical waste generated in the care of patients with known or suspected Ebola is subject to procedures set forth by local, state, and federal regulations. There's a link to an OSHA website that provides some of that information for you. So if you have medical waste that's contaminated with Ebola virus, it's a Category A infectious substance that is also regulated as a hazardous material under the U.S. Department of Transportation's hazmat regulations. So there's a website there where you can link out to learn more about that. The bottom line is this: used PPE and other medical waste must be double bagged and placed into a designated medical waste container at the receiving hospital or disposed of according to those federal guidelines. Here's some information from the Alabama Department of Environmental Management's Medical Waste Program, where you can learn more about some specific regulations in Alabama about management of this waste. Here's the CDC's medical waste management guidance that answers a lot of detailed questions about management of medical waste. And here's some key points from that material. Number one, Ebola-associated medical waste that's been inactivated, so autoclaved, cooked basically, or incinerated, may be transported as regulated medical waste. So once you've inactivated it, you can transport it as regulated medical waste, just like any other medical waste. Ebola-associated waste that's been properly inactivated or incinerated is no longer considered a Category A infectious substance and is no longer considered infectious. So that's very important consideration when thinking about medical waste. There's some references here that give you a little bit more details about those specific points, and also a list of permitted medical waste disposal companies in the state of Alabama can be obtained by calling this phone number. All right, so let's talk about some environmental decontamination issues in EMS. So once you transport a patient in the back of the ambulance, you think about decontaminating the entire patient care compartment. That sounds like a lot of work to me. So one way to kind of try to facilitate your environmental decontamination is to drape the interior of the ambulance's patient compartment with a water impermeable barrier, just plastic sheeting, prior to patient transport to make it a lot easier to decontaminate after completion of the transport. So what a lot of people have done is, purchase plastic sheeting, use some duct tape to tape it into the interior of the patient compartment in order to just make basically a shell of plastic sheeting inside the compartment. After you complete the transport, then you can just fold that in on itself and dispose of it as regulated medical waste. One pearl that we picked up from some providers who had basically dedicated an old EMS unit to these kind of transports is that check your unit periodically to make sure that the tape is still sticking and that the tape still holds. Because sometimes when you have temperature fluctuations outside, what you can see is the tape loses its stickiness and your sheeting may fall down. So if you do have a unit that you tape out ahead of time, be sure you check on it frequently to make sure that the sheeting is still in place. So let's talk about containment of the contaminated fluids. So Ebola patients, particularly when they become very ill, can produce copious amounts of fluids. They have a lot of vomiting, they have a lot of diarrhea, they may be bleeding. So they may require measures to contain those fluids during the transport, things like adult undergarments, absorbent pads, and maybe placing some water impermeable sheeting around the patient for the transport so that you don't contaminate your ambulance compartment any more than you have to. One strategy that some agencies have tried is, a plan that they have in place is to use just a plain mortuary or body bag, place it on the ambulance stretcher, and let the patient lie in that, and then zip it up just around so that the patient's head is still out of the bag. And that's a great supply that a lot of us have on hand that you can use to transport those patients so that you can contain those fluids inside that bag so that you don't contaminate the floor of your ambulance. All surfaces in the patient care area have to be cleaned and disinfected after transport. Anybody who's doing the cleaning has to be wearing the full PPE. So what do you clean with? So the EPA registers hospital disinfectants and says what they're good for and what they're not good for. So if you use an EPA registered hospital disinfectant that has a label claim for one of the non-enveloped viruses, you can use those to disinfect the environmental surfaces in the back of your ambulance. Disinfectant should be available in spray bottles or in commercially prepared wipes for use during transport, just in case you have some contamination that happens during transport. Alternately, a 1 to 50 dilution of household bleach prepared fresh daily can be used to disinfect environmental surfaces. So if you're not sure about your disinfectant, you can use bleach solution. That's perfectly acceptable. You can also use a 1 to 10 dilution of household bleach prepared fresh daily to treat spills before covering them with an absorbent material and wiping up the spill. So that's another strategy that you can use if you can't get your other disinfectants. The downside of using bleach is obviously it smells like bleach, and that can be noxious to a lot of people, but that is an acceptable alternative. So let's talk for a few minutes about personal decontamination. So when you're caring for a patient, you should do hand hygiene frequently. Washing your hands, wiping them off with a disinfectant wipe. A lot of people talk about using alcohol-based hand rubs. You want to be careful when you're using alcohol-based hand rubs because some of them can compromise the integrity of nitrile gloves. So you just need to read your manufacturer's specific recommendations for whatever glove you're using. It's okay, if you use it once or twice, you're probably fine. But if you're wearing those gloves for an extended period of time, you could get in trouble if you're using a lot of alcohol-based hand rubs. So, you might want to think about soap and water washing as well if that's available to you, or using disinfectant wipes as well. After you care for a patient with Ebola and remove your PPE, you want to shower with soap and water, particularly if the patient was experiencing copious fluid production or if there's any suspicion of self-contamination whatsoever. So what do I do if I'm accidentally exposed to a patient with Ebola? You know, if I have a needle stick, or you know, I got vomited on, or my PPE failed, or whatever happened. So if you are accidentally exposed, you should immediately wash the affected skin surfaces with soap and water. You want to clean yourself. Mucous membrane exposure, so in the eyes or the mouth, you want to irrigate that with a large amount of water or eye wash solution, so wash it off. And then the next thing you're going to do is contact your occupational health at where you work, your supervisors, and receive medical evaluation and follow-up care. Then we'll need to consult with ADPH for the monitoring requirements afterwards. And certainly, you know, if there's ever any problem, ADPH is happy to consult and help you figure out what your risk factors are, and to work with you if you are indeed exposed in that manner. Let's talk about reporting for a minute. So any case that's confirmed or suspected of a viral hemorrhagic fever, which includes Ebola, must be reported immediately to the ADPH. Okay, that's not a new rule. That rule's been in place for a very long time. So after you complete your patient care, EMS personnel have to contact the ADPH Epidemiology Division at this phone number, 1-800-338-8374. Okay, that's different from calling ATCC on the front end. This is in addition to that initial consultation with the ADPH Office of EMS physician. So when you call ATCC at the beginning of patient care and you talk to me or you talk to Dr. Crawford, we're going to talk to the Epi Division, but when you finish all your patient care, they're going to want to talk to you too. Because you may have additional details that you didn't have when we first talked to you, and there's going to be some other information that they would like to get from you. So you must contact them. It's required by law. So if the patient gets transported to the hospital, they're not going to have a lot of questions for you. It's going to be a pretty brief conversation. They're going to ask you about the patient's name, where you took them, very basic information like that, because then they're going to turn around and call the hospital, and the hospital is going to fill out a nice form for them. However, if the patient is deceased, or if you ended up not transporting the patient for whatever reason, you know, who knows what happened, but if something happened and you didn't transport them, then you have to complete what's called an Alabama EVD consultation record, which is a 5-page form, which is not as bad as it sounds, and submit that to ADPH. So when you call that 1-800 number after you complete the patient's care, they'll talk you through anything you need to do. The important thing for you to remember is that you have to report these cases. Now, what do you do if you lose that phone number? Well, it's on the website, and I'm going to tell you about that in just a minute. All right, so what is ADPH doing to help us get ready for Ebola? Well, let's talk about that, because we're doing a lot, actually. We've established an Ebola planning and response team, and it's taking up a lot of our time right now. We're working on making sure that we're prepared. So we have an epidemiology branch, we have an emergency preparedness and response branch, a healthcare branch that includes medical, nursing, EMS, pharmacy, lab, and dental, a communications branch, and a legal branch. So we have a lot of people at ADPH who are working on Ebola every day and have been for months to make sure that we're ready just in case this disease comes here. We're actively monitoring people that have arrived from West Africa who are at risk for Ebola. So we're doing that every day. We do have people in the state of Alabama who are at risk, and we're watching them and working with them to help make sure that everyone stays safe. We're developing, updating, and disseminating guidance and information on a daily basis, and we're working with all of our partners, which if you're watching this video, you're one of our partners. We're working with State EMA, we're working with the Hospital Association. I'm sure I've left off a ton of other organizations that we're working with on a daily basis to make sure we're all prepared. We responded to inquiries from healthcare providers, from the public, and from the media. I know there's been a little less media attention around Ebola in the last week or two, but that doesn't mean that Ebola has gone away. As I presented early in this presentation, it's still a very big problem and still something that we need to pay attention to. We've developed some toolkits that are kind of geared for specific providers. So we have one for the hospitals, for EMS, for nursing, for urgent cares, pharmacies, labs, and other facilities. So we have several different toolkits. this is what our website looks like for Ebola. So it's adph.org/Ebola. And if you look on the left column, you'll see there's a menu there. And if you click on healthcare providers, that takes you to this page. And you'll see down at the bottom there's an EMS toolkit, and that specifically is where you'll find the EMS information. So what is there for you? Specifically the guidelines for patient care for patients who are suspected of having Ebola. At the bottom left of this slide you can see there's the header from what that looks like. So we have very detailed guidance. We're on update number 3 of that guidance. It's very detailed and provides the information that we went over today in very explicit detail so that you can see exactly what you need to do. In addition to that, there are myriad other resources. A lot of this mirrors what the CDC has out there. A lot of it links specifically to the CDC's guidance. And then some of it is tailored very explicitly for the state of Alabama, such as our EMS guidance. And as you can see, there are multiple different resources available on that website. So it's a rich resource. It's updated continuously. I would strongly encourage you to use it. So for more information and summary, go to www.adph.org/Ebola. You're always welcome to contact the State Office of EMS, and our staff's glad to help you with any questions as well. Here are some references that you may find useful. Always remember the CDC's website is a fantastic reference as well. Well, this concludes our presentation. Do we have time for any questions from the audience, or do we have any that have been sent in during the broadcast?
We do not have any emails.
Okay, fantastic. Well, I guess at this point we'll conclude our presentation. Dennis, did you have anything else you wanted to add before we conclude?
No. Thank you.
All right. Well, thank you very much for paying attention to this broadcast. And once again, we're available if you have questions later. Feel free to email them to the EMS office. Feel free to call us and certainly refer to those websites as well. Thanks for your time.